Welcome back to Care Transitions Today. This is a healthcare podcast with a focus on case management and transitions of care, and it's presented by the American Case Management Association. I'm your host, Deb McElroy. Before we begin today, we have a brief message from the American Case Management Association. Please join your peers at the 2021 ACMA National Conference, June 22nd through 25th in Orlando. Engage and learn with case management and transition of care professionals from across the country at this premier event. The conference offers a lineup of healthcare experts presenting sessions designed to improve patient care outcomes and also prepare attendees for success in this, as we know, ever-changing healthcare system. Learn more and register at casemanagementconference.com. Today, we're going to continue with our innovation theme, specifically focused today on innovation in emergency preparedness. And I am delighted today to welcome our guest, Marlene Bober. Marlene is currently the Vice President of Practice Development at the American Case Management Association. And previously, her previous role was the Vice President for Integrated Care Management for Advocate Aurora Health Systems, 500 sites of care, and 27 hospitals. She has more than 20 years of experience as an executive nurse leader, spanning many care settings, as well as quality and utilization management. But it's a perfect time to welcome my friend and colleague because she has recently authored Preparing Viable Transitions, an ACMA crisis management guide. And as we continue to navigate these turbulent waters of healthcare today, I think she's the perfect person to have us to join us. So Marlene, obviously we talk about emergency preparedness. We have been navigating this crisis with COVID for a year. So as the COVID crisis evolved, ACMA supported its members in responding to the myriad challenges that arose. Can you describe for our audience today the importance of the role of case management and care coordination in these types of situations, these crisis environment situations?
Well, thank you, Deb. I really appreciate being here today to share my story and what we've encountered over the past year. And yes, I truly believe that case management and care transitions are so important during these times. The COVID-19 pandemic has really created a world crisis. And as our healthcare industry takes a step back and reflects on 2020, one question is at top of mind for all of us: will we ever get back to normal? The crisis has taught healthcare delivery systems and case management leadership specifically to rethink our position on several fronts, looking at staffing, looking at remote workforce, redeployment of clinical services, emergency preparedness, telehealth or telemedicine, discharge and transition strategies, and particularly what lessons have we learned amidst this crisis. As we reflect on the coronavirus pandemic, we all can acknowledge that it has had an impact on case management and transitions of care. So what did we know before life changed with this pandemic? Case management and healthcare delivery systems is a collaborative practice that works with patients, caregivers, nurses, social workers, physicians, and other allied health professionals in the community. We are responsible for facilitating communication and care coordination along a continuum through effective transitional care management. We have to be able to recognize the patient's right to self-determination, the significance of social determinants of health, and the complexities of cares, and the goals of case management that include optimal health, access to services, and appropriate utilization of resources. When we think of care across the continuum, we need to be mindful of the impact that COVID has made to our patients and our families. It's no longer business as usual, But more importantly, it's time to evaluate how do we react to the impact with our policy changes, with staffing choices, training needs, and how to take care of other healthcare professionals.
So that's great. So you've set a big stage there, and there's a lot to unpack. So maybe we can go through a few of those things. Um, you're talking about planning and strategizing is in terms of preparedness. And so healthcare systems obviously have lessons learned. We've heard a number of those on the podcast that we've had before, lessons learned, but they're planning for the future now. And what should, they be thinking about as they prepare to face a similar or maybe different kind of crisis in the future, but really pulling forward some of those threads that we've seen over the last year?
Well, we know, Deb, that things have changed significantly in our practices. And I believe that just going through and listening to stories from healthcare professionals and case management across the country, you're right, we do have a lot of lessons learned. I think those are things that we need to take into consideration as we plan for the future. I will tell you that one thing that really hit home to me is we've not been through this before. And in my previous experience in several roles, whether that be hospital leadership, nursing leader, or in case management leader for a system, I know that are we always as prepared as we should be in looking at having a plan for case management specifically. I think it's very important for us to consider having a tool that helps us during a crisis. I guess as a nurse, all about checklists. And, there's things we all forget. And this new tool that I've created, which we'll talk more in detail later, really helps a case management leader to make sure that she has her T's crossed and her I's dotted to ensure that she has a well-developed plan for his or her department. But I think we have to ask ourselves, what does healthcare look like once we pass this crisis? I still hear about capacity issues today and what's going on, so I don't feel that it's totally over yet. What are things have we done differently? We need to really look at that. And did we gain any lessons learned that we've heard across the country and shared with our peers? And how to do our jobs as case managers in a different way and more efficient way? We know that many folks have been pulled into many different roles, and we're trying to fill the gaps where our hospital system or communities need us most. Others have remained in their current departments dealing with higher caseloads and having a difficult time placing patients in their hospitalization. But I think it's all about keeping leadership composure during a crisis and being there for a team of physicians and nurses, social workers, patients and families, and really making sure that at the height of a crisis, we are very well prepared. As we are being overwhelmed with some of these unpredictable circumstances, whether it's regulatory changes, documentation requirements, and other emotional and physical demands of the job, we're going to lose track if we don't really inspire our people to ensure that we have a solid plan moving forward. One key thing that I heard during a lot of the interviews that we had was a common theme repeated by leaders from healthcare systems in major healthcare organizations. And most of that was stepping up and not back. Most noted that many of their staff stepped up, and that was very important for them. They took on new roles. They did things differently. They came up with creative ideas and innovative ideas, and were thinking outside the box. During COVID, sometimes there were no good answers, and sometimes there were many answers coming from many different directions. Regulations, directions, and best practices were coming in from various levels of the health system, and sometimes they were contradicting one another. So I think this is why a conductor has to organize those sources and services across and really kind of lead it in such a way into a musical performance. So we have to make sure, do we have everything organized in a format so that we can make sure that we have been able to communicate with others across the healthcare system?
So I I love that, but I do see some organizations maybe saying we thought about that pre-COVID, and then we got into this uh, very emergent situation, and there were some things. So, just off the top of your head, is there anything different? Um, is there anything that looks different now than maybe what you would have thought about in terms of planning pre-COVID?
Sure. I think a lot had to do with folks really just how are they going to possibly relocate their staff? That's one of the things that we heard where should they work from home? Were they an essential worker that needed to be on the team? Absolutely. But it was critical in the very beginning about conserving PPE and not having case managers and social workers go into patient rooms. So that's one example of folks determined that they weren't going to go in and necessarily have them do the interviews in person. I heard from several organizations where they did allow their staff to go in, and then they had a crisis that they dealt with because of staffing, because everyone caught COVID. And so then they had to pull from other hospitals in order to supplement their staff. I think it's important that, during a crisis, having a full-fledged plan just for your department in general is necessary. Rethinking things like uniforms. Could these folks wear scrubs? Try to appropriately not carry things home where they could wear the scrubs at work, change their clothes before going home, and so forth. Little things like that case management would never have thought of in previous years.
So really, you're talking about your checklist. I mean, pretty granular stuff that ended up being critical.
Absolutely. Going down to the basics of some of the details with staffing, workplace environment, and so forth. Those are all key things that we may not have gone down to that level and really thought clearly about.
That's great. I know from the podcast that we've been doing that a theme that arose was the communication within health systems, but also throughout the community networks. All of that has been an essential component on how there was an emergency response, and to your point earlier, addressing capacity issues. What have you heard are models that we can take forward that might help us be successful?
I think when we talk about communication, we've all had to think about it differently as we assessed our patient needs and how we as case managers respond and gather additional resources for the patient that goes home during the pandemic. I had one case manager leader tell me she had been out on vacation just when the peak of this started. And boy, she wished she would have had the checklist in place with those items and things prepared so that her manager, her supervisor, coordinator would have had all this information at the fingertips of what to do next. Sometimes we don't think about that, think we're, indispensable and people can figure it out while we're gone. But when she came back, if she would have had that checklist in place, things would have been going along a lot smoother. I think just having key contacts of folks and information, whether that's internal and also external, from key payer contacts to key health department contacts to folks that may be your post-acute in your skilled nursing facilities, all of those in a document that could help support and know where to go and what to do are really something that we try to accomplish with creating this new pivot tool. A patient who's COVID positive and being discharged home might not have had the resources that they did prior to their onset and diagnosis. And for the elderly, it's really assessing their needs and asking different questions that we may not have asked before. For example, can somebody deliver groceries to them? Because if they had COVID and they were in the hospital, we didn't want them going to the grocery store. But think about it. If I think about my mother or grandmother, would they be able to go online and order groceries? No, but is there somebody that could help them order? Could we do something? Are there deliveries, or Meals on Wheels was what we're used to, but it's going to the next length. And what are some of those solutions? I think also we saw a lot of pharmacies step up to deliver patient medications. We would have never asked, are people going to deliver your medications for you? And is that a possibility? And what about telehealth visits? I can tell you right now, even in my own family, would my mom be able to do a telehealth visit over FaceTime? Unless I initiated it, it's not going to happen as a, for as a daughter to her, helping her to make sure that she has that visit. And so I think we've got to be very creative and innovative in ways to really reach our patients and look for resources outside of our norm. And I think that when ensuring a communication plan, we have to make sure that it addresses effective discharge care strategies. And I think there's a lot of things that we need to consider. Like, how does your organization stay abreast of all the legislative rules that impact your organization and patients? Have we thought about letting our folks know? And how do we get that information and we know what's the source of truth or the correct source of truth and disseminating that? That's a form of communication that not only has to be thought about with our patients and families, but also internally with physicians, our staff nurses, and folks that normally don't deal with some of the things that a case manager or social worker might deal with.
So I'm going to circle back because, again, what I hear you talking about are some of the essential components that you need to plan for and strategize ahead of time. Some of them, the example you gave with the pharmacy that might not have historically, in terms of delivery, historically been on a list. But you use the term the pivot tool, and I'm not sure we talked about that exactly. So can you walk through the checklist that you've been talking about and the resource that you've developed is called Pivot? And can you just talk about how you arrived at that? And then we'll circle back, a little bit of a sidestep, but I think it's interesting to note.
Sure. So, in really trying to look at how could I help the 8,000 plus members we have from ACMA really, what are some of the things that they need? And somebody had mentioned to me, gosh, it would be great to have a checklist of all these things that you're mentioning, because ACMA stood up. We did a lot of webinars. We had frontline folks from New York and other healthcare systems across the country who really talked about what they were dealing with. But in a way, it was different. It was different at every state level, of what folks were going through. And I think an overall checklist is something that I heard of and thought, is there anything out there that we currently could use as a best practice? And in my research, didn't find anything. I know that the CDC is a great source for checklists for patients and questions and things like that. And I know that we are required by not only federal and state laws. CMS requires us to have an emergency plan for our hospital. But what did we have specifically that could really help drive a checklist within the case management department? So it was important for me to create something that would help. So in my interviews with folks across the country, I looked at some kind of key places as to what it would be that they would want in a checklist. So again, this doesn't take the place of an emergency plan that your hospital has. It's up on top of your emergency hospital plan. What are some specific things that you could utilize in your own department? So I looked at adding to that, looking at patient flow and expedited discharges, key contact information, communication, staffing plan, whether that would be on-site, working remotely, and redeployment, and also patient advocacy. And then what are we doing to really help staff resiliency? So it took into many areas of things that you could take and deploy. So for instance, one of the things that I was used to in communicating to other folks is having what we call an Sbar format. Some folks are aware of this, but it's called situation, background, assessment, and recommendation. How do you keep a message that it can be so complicated, such as a regulatory change? How can you put it into a simple format that can be communicated to an entire physician staff or medical staff for them to understand, or even to your own staff? So things like that would help us ensure our communication is brief but on point. What are the things that you as a case manager leader come to an emergency hospital planning meeting with making sure that you have all the top information, such as how many beds are available, how many patients in the ED do you have that you could potentially work with the physicians and get them discharged if appropriate, cases that you have up on the floors that may have delays. Bringing key critical pieces of information to a team meeting for emergency planning is crucial for case management to be involved. And so this checklist really defines each of those things in all the different areas that I just spoke of.
I think this is a checklist that probably will be used more than once and in a more dynamic way because the regulations are being responsive and may change over short periods of time.
Right. This checklist was developed with the auspice of thinking, could this be used within another crisis that we may have, such as, COVID pandemic, or something else. But I think that, as ACMA looked at even addressing and trying to take apart all these rules and regs that the government came out with and waivers, it was very complex and people just wanted to know. I will tell you that we held a webinar early, probably, I'm probably going to get the date wrong, but I want to say somewhere in March or April, we held our one of our first webinars with our public policy committee. So we had Pat Kramer, who's our chair of our public policy, with Max Perkins, who did a great job unpacking what all of those federal regulations and the waivers meant. We had over 1,000 folks on our webinar and had great questions from everyone. And it was just great information sharing. And we need to do more of that. We just held one again recently because of the new administrative change within the government. And the same thing again, had a great turnout, great questions. Max and Pat did a really phenomenal job unpacking what are some of these new waivers, what's continuing, what has stopped. And I think that's important for leaders to be able to go to an organization that they can trust to know how to interpret some of these guidelines. We do encourage you to also go through your compliance or legal to make sure that you are interpreting for any type of waivers or things at your organization. But this helped give them an overview and gave them the idea about what questions to ask. I think it's really important as we go forward that we continue our work with public policy so that we understand things.
Wonderful. That component, I think, regulatory space, I can truly see the application of the checklist being critical. I'm also going to want to circle back a bit to your comments around staffing. Obviously, there was change in where they were located and how that was working. They really had to pivot, and you've given some examples of that. Is fundamental is who goes in the room and what they wear, some of the things you talked about earlier. When you think about preparation, how do you think the staff helps inform doing that departmental plan that you're talking about? And what other considerations do they need to think about as they develop an emergency plan, specifically for case management?
In speaking about staffing, whether remote versus on-site, we do have some great lessons learned. And one of them really is what we need to consider in the environmental proximity of staff and have our deployment strategy on file about when we are faced with needing to distance. I mean, whoever thought we were going to have to distance our staff from one another? I think one of the things that you have to recognize is that space is a commodity in a hospital, whether you're in a COVID pandemic or not, right? Where are we going to put these folks? A lot of time they're very stretched on a nursing unit where there's so many folks and not enough space for everybody to be. And especially where infectious disease can spread quickly, space is at a premium. So our case managers are already used to working in small places, sharing with multiple team members. And when we have this, it's, given the nature of this, it's imperative that leaders really consider where will on-site staff work and the risks of those environments, especially during the pandemic. Many of them took over space that had been vacated by leaders who were now remote. So some leaders that maybe have worked from home gave up their offices for case managers and social workers to work in. Convening staff for disseminating information as a team. Some had auditoriums that they took their staff once a day where they held their huddle versus trying to do it all in their break room, which they normally would do. And I think that staffing has been another factor in our ability to do our job. Some organizations selected remote work to reduce the use of PPE. And I think as we're rethinking the workloads of our team going forward to balance the needs of our individual hospitals and organizations, we have to figure out how we're going to redeploy any type of clinical services, because we definitely know that as we look at that in our checklist, we specifically talk about working to the top of our licensure. Do we have the right people doing the right job and working to the top of their license? And so let me give an example. We had we had case managers who may have just come from a nursing unit or nursing floor and became case managers. So relatively not that far removed from working on a nursing unit. We know that those folks were okay to go back to the floor, but at the same point, we couldn't have a social worker do the same role and job as a case manager just because of working to the top of their license. We needed to make sure that our social workers were able to do their psychosocial and their assessments of our patients, help with the discharge planning. And if there were any other ways that they could help, we needed to make sure that was within the scope of their work and their licensure.
And just any of the social determinants of health, I would think they were really helping to navigate anything from transportation to some of the really critical pieces like food security. So everyone's job became vital, just it's where do you put them?
Exactly.
The things you've talked about have some pretty concrete ability to take a look at what we did, how do we plan for the future, what are the pieces that worked. There's some equally critical pieces, such as how do we support our patients and their families in a crisis. This had some unique features, and hopefully we won't experience something similar anytime soon, but there may be components we can't plan for, but that I would think has as much planning that needs to go into it as some of these more concrete pieces that are easier to evaluate and plan for. So can you talk about how this checklist or tool maybe addresses that piece on patient support and family support, kind of following what we were talking about in terms of the social work contribution?
Sure. I think it's important to recognize that, again, lots of lessons learned. We didn't start the pandemic with having a multitude at our fingertips of iPads, right? Or iPhones or other technology to be able to utilize with conducting patient and family conferences. And so I think that a lot of leadership across the country stood up, really decided that they know that we have to have ways to communicate, not just when their patient or the family member was dying, because in a lot of cases, we heard stories all over the news about folks being able to talk with their family member who was hospitalized and didn't have that capability. And I really think the healthcare industry has stepped up and really looking at how do they provide those resources to be able to conduct those patient family care conferences, or have I know if it was me and I had a family member, I'd want to be able to see what that physician was trying to say to me about my loved one, and making sure that I understood what are the risks, what are the complications, et cetera. and what choices did I need to make? So facilitating in a different way that we've never done before, which even took nurses using FaceTime on their own cell phones and contacting family members or having them be able to speak to a loved one, was key in all of this. And how did we stay in communication with them and really help drive safe and seamless discharge plans for the patients themselves. And so I think, again, as I mentioned about thinking about things differently, it was important for us to go down that route to having technology help support us. And then think about, a patient, maybe elderly, has a daughter or son who's got their own family. They don't want to get infected. We don't want them going over there getting more infected. This is really about this whole infectious disease process of not spreading COVID. So we had to make sure that we could plan and really give clear, concise instructions, whether that's you drop off the groceries at the door and leave and do not go in, and whatever that may be. But, is there any support that they can give and provide their family member to make sure that they were safe at home? And then also having the patients and families, sometimes there's a lack of that technology in the home. If they have an iPhone or another type of phone, does it have the ability to do some sort of a FaceTime or do a telehealth visit with a physician, so that we didn't have to have them go out into the community trying to get a ride to a physician office? If we can and the patient was stable, how did we create that telehealth? We've had a lot of organizations come up with some pretty creative telehealth, telemedicine plans of conducting those home visits. And I think that the government came out and really helped support and drive so that hospitals and organizations could get reimbursed for that.
So the checklist, it really has these prompts,
Yes.
right? That deal with not just some of those more concrete issues, but how patients and family are supported. I guess I would ask, does the tool or the checklist also address sort of those kinds of things around stress and for staff as well? Because I just read an article today about the toll this has taken on all of our healthcare workers. This article was on physicians, but is there anything in the tool that helps organizations sort of think about that?
Sure. I think that we talked a lot, especially in the paper that we wrote that complements this pivot tool, to talk about staff resiliency. The emotional impact on staff as a result of all their experiences during an emergency, especially during the pandemic, can't be underestimated by any of us. And it's critical that we address the emotional well-being and resilience of our staff in addressing the stress that they've gone through. And research has demonstrated that staff experience anxiety, fear, social isolation, insomnia, other things, and also concerns around the lack of information. So the more things that we can do to work with our teams as a leader is important. So some of the things that we listed in our checklist are like, are we providing formal and informal opportunities for the staff to express their feelings? Are we developing some sort of empathy circles for staff to discuss their experiences and concerns? Are you providing pastoral care and behavioral health interventions? You might need that. And a lot of folks have already the use of employee assistance programs. So how are you really calling on EAP to help your employees and associates deal with that? Some even have created like a Zen room where, is a place for them to go and just during this time when things were crazy at the hospital to be able to go to. And it's been very, very helpful. But I think as a leader, we have to portray something different, but it doesn't mean that it doesn't affect us as a leader as well. We have to make sure that we all take care of ourselves. And I know one of the groups that we talked to had mentioned about going around in a circle during a huddle and talking about either a positive thing or something that they just wanted to share with the group. And if you said, today I don't have anything to share, made sure that the next day you were called upon so nobody gets left behind, and you really try to be inclusive of everyone.
So I'm curious as you were putting together. So this is obviously robust thinking around strategy and planning and the emergency or the crisis we've just experienced and what might come down the road. Is there anything as you were pulling? You talked about the research you had done, plus pulling on obviously your significant experience. Anything that surprised you as you were pulling together the paper and the tool? Anything that surprised you as you were working on it?
Um, I think because this is something that none of us have ever gone through before, it was probably all very surprising. But what I felt kind of two themes, and I mentioned one earlier, which was case management really stepped up, not only the leaders and their staff, and they took on what they needed to do to help the rest of the nursing staff and physicians do what was ever needed to really help in this time of the crisis. So that's the first thing. And it didn't surprise me. I knew that this is a group that's caring and one that really wants to be a collaborator and a team player. So this made me very proud, actually. And so very happy to hear that. But I think the other piece, I was and not surprised, but very happy to hear about some of the innovative things and people thinking outside the box. So I'll give you an example. One healthcare hospital actually shared with me that they were getting an influx of patients from a group of assisted living areas, homes in the area. Couldn't understand why all these people from one specific area are flooding the CD. Well, when it came down to it, and the care management leader went down to the ER to kind of she found that it was from one. It was from one assisted living centers that was sending all the patients because they had symptoms of COVID. And instead of sending them there, she got creative and said, could we get a staff person from the hospital to go do all the testing and prevent them unless they were critically ill? And all it was is they were sending patients that were taking up the space for others that was much needed. And this leader said, let's get somebody out to the assisted living. And so they did, and they did all the testing and got that taken care of. So really this notion of creative thinking and innovative thinking and thinking outside the box, this was another big key that I was really happy to hear lots of different stories about that.
I think the stories really make it come alive. And I think never before we've heard this in other podcasts, as well as the story you just told. The community network, folks are so integrated in helping to address a crisis and deliver that needed care. So ACMA has the tool. You've obviously done a ton of work on this. It developed pretty quickly since we're still in the midst of navigating these times. Anything else that you want to share with the folks listening? Just a little more detail or description, or how you're deploying this for folks to use?
Yeah, just a couple things. I'd like to be able to talk about what do we think about the future, but I do want to say that I'm happy to say that ACMA has really stepped up and created a COVID page on our acmaweb.org website. That really is a page that we've kept all our resources on, keeping current with current regulatory and policy implications. And we also have our learning link that serves our 8,000 members for really sharing any best practices. And I'd recommend to anyone about utilizing those tools.
Is your company interested in exhibiting at the 2021 ACMA National Conference? We would love to have you join us June 22nd through 25th in Orlando. In addition to providing continuing education, the conference hosts an exhibition, allowing attendees time to network with representatives from external facilities that provide resources, services, and products critical to patient care delivery systems. Learn more at casemanagementconference.com.
I think as I mentioned earlier, it's really no longer business as usual any longer. And we're really rethinking not only case management processes, but we're looking at hospital processes and things that have happened, and evaluating how COVID has impacted them personally, and I think learning from it in the future. Because as I can tell you, there have been calls where folks have learned they need to have a better relationship with their post-acute facilities, or they needed to make sure that they better understood during a crisis how they can work better together. That's key. I think healthcare technology will really focus on assessing what additional technologies are needed, and I'm happy to see that they're being addressed in this day and age, because I think patient and provider communication and patient engagement is key to all this, and how we make sure that we keep up our communication with them. I think that organizations are expeditiously working on having a telehealth program, and the demand for this is key, and how you set that up. And I think there's going to be folks that learn from that. I think even such minor things as looking at scrubs, for our case managers and social workers. Is this a thing for the future, or, do we need to think about redoing that within our hospitals and healthcare? And I think that the strain of this has really brought in the cream of the crop up to the top for our healthcare organizations, our staff, and really identifying those who have stepped up, which is really great to see. But I think that we need to continue to participate in these innovative teams, at our organizations, think outside the box, share things with us. We're happy to work on things that would make your life easier in any kind of capacity, especially at a time of crisis. And I think case management is the avenue to help us rethink our strategies and improve patient care for the future. We all need to really reimagine tomorrow's workplace. We'll prepare ourselves to better meet the needs of our staff, our organization, our patients and their families, and the next unexpected crisis. What does that mean for us, and how can we be better prepared? We can collectively as a group learn from our experiences and share our knowledge. And I think that, to me, is the best medicine out there about how do we learn and share our stories amongst everyone. One story that I would like to share that was very heartwarming, and I was actually moderating one of our webinars with a physician and a nurse leader from New York who were right in the midst of all this. And I could, as I was moderating it, I felt the chills go through me when they were describing what they were seeing, not only in the hospital, but the nurse had described, this nurse leader was very explicit and described, she was going home one night, it was late, she was tired, and it was just one of those bad days, and she just made it through it, and she was just happy to go home. But when she walked out through the ED to go to the parking lot, she noticed to her left the big trailers that were out there with all these bodies that were in it. And she right then there said what an impact that made to her, just thinking about all the work she was doing, and how that's all that she should be thinking about is our patient care and what we do for our patients, and how do we get through this together as a team. And I think in your very first question, Deb, you mentioned to me about how does case management fit in with, how have they stepped up and how important are they to an organization? They're everything. They are part of bed control and facilitating discharges, but they are also those that are really helping our patients along with our nurses and doctors and other ancillary folks, and really making sure that we can see them go home and have a safe care transition back to their home and to their family. So I think it's really important for all the work that we do each and every day.
Well, profound words. And I know that you have sat in the chair as a leader over a system. The folks that are doing this work. Any final comment as we wrap up, as somebody who's been there, that you would say to the people who might be leading this emergency planning and strategic planning for the future?
I would just like to wish everybody the best, and to continue to make sure that they realize we recognize all the great work that you're doing each and every day, and how important this is. Again, how we collectively work as a team. And in coming from a large healthcare organization and moving to the ACMA, I had my my hat on both ways, thinking, how could this help me if I would have still been in my role? And I think that anything that we can do as an organization for all of our members, any way that we can support you through webinars or different topics you might want to hear, or checklists or papers, or sharing our collective experiences, we are happy to be right there with you because we support each and every one of you.
Well, thank you, Marlene, for sharing your experience and expertise today. We applaud and appreciate all you've done through this as well. So thank you for joining us today. To those who are listening, if you have enjoyed listening to the podcast, please leave us a rating and a written review so we know what you think. Any ideas? Marlene just said it. Any ideas? Happy to hear those as well. Please don't forget to subscribe to Care Transitions Today so you're notified when we upload new episodes. Thanks for listening.